The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for August 21st. This is, again, Deanna Mitchell at Leading Age Michigan. And as of today, it looks as if the recent increases in cases and deaths has leveled off for Michigan, and we're certainly hoping that will continue. But overall, the pandemic does keep on, and we know that it continues to wear on all of us. So today, our agenda includes our routine topics, but we're going to focus heavily this morning on the work of the Governor's Nursing Home Preparedness Task Force, because one of the biggest challenges in front of us is the probable second wave that may be coming down the road this fall. So we're going to start with a very brief advocacy update, spend the bulk of our time on updates from the task force, look very quickly at the Michigan numbers, and end with a very few resource and guidance updates. So we will now turn the presentation over to Dalton, our Director for Advocacy.
Good morning, everyone, and thank you for attending today's call. You'll notice we do have a couple more handouts than usual in the handout section of today's webinar. Just a reminder on that front. Today I have an exciting opportunity to talk to you about Aging in Adult Services, partnered with Advancing States to provide a web portal to help address ongoing staffing concerns due to the pandemic, and we were facing staffing concerns before the pandemic as well. This opportunity is available to licensed provider types, and currently there's over 150 job seekers that have already registered with the portal, and it's completely free for anyone who wants to utilize this opportunity. MDHHS did send out an email, but they didn't have everyone's email. I posted a link to the portal there and a link to their questions email there in case you have questions. And on the next slide, we'll go over how to register to get access to this free job recruitment portal. The directions for registration include you have to sign up and create an account on the portal, which is right there. I posted it via link, and so you can see the actual web link. To verify your account after you created it, they'll send you an email with the code. Then you have to sign in, click on the Tell Us About Your Needs button, fill out the form about which positions you're looking to hire for and what are your needs and the dates and the times, and then click Submit. And at that point, it'll act like a normal job board. Your post will be out there, and then job seekers can go and look through all these posts, and it's completely free for licensed providers. So it's a pretty exciting opportunity and something that Aging in Adult Services and MDHHS are quite proud of. With that, speaking of exciting opportunities, I have the exciting opportunity to introduce David Herbal, the President and CEO of Leading Age Michigan this morning. Dave is going to join us to discuss our upcoming virtual leadership event, and he's also going to be discussing the Governor's Nursing Home Preparedness Task Force as he represents our members on that task force. He will be providing an overview of that body's work to date, as well as his individual work on his own task force. And then we will follow that with summaries from each of the task force groups. And so at this point, I'd like to welcome Dave to our Safe and Calm webinar.
Thank you, Dalton, and good morning, everyone. It's a pleasure to be here. Another beautiful Friday. It's too bad it's the middle of August already, but you know, we'll get by with that. I apologize for all of the attachments that I wanted included in today's webinar, but I thought they would be valuable to folks who wanted to download those and maybe do some additional reading as I move through my content. So with that, what I'd like to do is just encourage everyone to take a look at the Leadership Institute brochure that was attached and let you know that registration is now open. We've spent a lot of time thinking about what speakers and subject matter experts would be the best for our membership during this challenging time. we really wanted to be able to offer folks just more information beyond everything COVID, but also talk about the upcoming budget dilemma that is existing out there. So, we're going right to the experts with a lot of great financial presentations that we're going to have on tap. We're going to have the director of the House Fiscal Agency, who's, in the middle of every legislative discussion around Michigan and its totality in our economy. We're certainly going to have our good friends from Plant Moran help members understand not only what's happening in the rate setting process, but the provider tax has had some nuances in the last couple months, as well as other exciting things like implicit bias training. We're going to have a fundraising and strategic communication session. And then we're also going to hear from our own members. Steve Kastner from Trinity is going to be presenting on an innovative approach to managed care plans in Michigan. So this is going to be a really exciting institute. The content is very robust, and I think you'll find it to be a very interesting session and a lot of good content there for you. So please take a look at that brochure when you get a chance. And if you're a business partner and you're interested in wanting to talk about sponsorship, getting your logo in front of the members, and potentially having a speaking opportunity at the conference, please connect with Blake on our team. He'll be happy to take your call. Additionally, one of the attachments that I sent out to you is an invitation from to a phone call with Dr. Khaldun. I believe it is on Monday. I'd ask you to take a look at that, see if that interests you. For those of you who are listening to the press conference last week, Dr. Khaldun mentioned that outbreaks were occurring in long-term care facilities. And, your advocacy team got all over that and contacted Director Massey and asked if we couldn't learn more from Dr. Khaldun about what that really means. And so she's been good enough to put together a webinar for us, a phone call, and we'll be able to hear what her perspective is on the environment in Michigan and the spread within long-term care facilities. So I think that's a very important call. For those of you who are interested, please dial in. Blake, next slide, please. Thanks. So just to touch base, I'll give you a little refresher on the governor's task force. So in June, the governor issued Executive Order 135 that called for the creation of the Nursing Home COVID Preparedness Task Force. The task force calls for representation from the legislature, MDHHS, LARA, and the Department for Departmental Leadership, and 13 other appointees. Here's the list of the 13 other appointees that are on the task force thus far. The charge of the task force, the primary charge, is to adequately inform the state's response to the potential second wave of COVID-19. And then embedded in that is that the task force is going to produce for the governor recommendations by August 31 that's going to develop an action plan on how to prepare nursing homes for any future wave of COVID-19. To that end, there have been 4 small work groups that have been developed to talk about what are the best practices that we should be developing to prepare Michigan for a potential second wave. And you're going to hear about those today. The 4 work groups are quality of life, resource availability, staffing, and admission of COVID positive residents. I certainly would like to thank our membership for stepping forward and volunteering their time to participate in these work groups. It really is rewarding to see our members stepping forward and wanting to get involved in these groups. We've got 12 members on 4 work groups, and I think we're very well represented, and showing everyone just how dedicated we are to helping solve the problems. Thus far in the process, there are 28 draft recommendations moving forward, And it looks like there'll be vetting of 4 that will move forward for more immediate action by the governor's office. Keep in mind that this task force is designed to get some quick moving recommendations that they can implement potentially for a second wave in the fall. All of the recommendations will be reviewed. They won't be set aside, but they'll also be worked on throughout the next year or two as the task force sunsets 2 years from its initiation. Next slide, Blake. The work group that I was added to was admission of COVID positive residents. And we really focused on 4 primary areas. The first was hospital capacity, the second regional hubs, the third was non-hub facilities, and the last was the development of COVID-only facilities or alternative care centers, if you'd like to go there. So our first recommendation is really one that was quite interesting, and 2 of the attachments that you'll see on the screen to your right, I thought were really good background information that I wanted to call your attention to before I jump into reading about the recommendation. But the one attachment there, you'll see LARA and BCHS surge capacity. These were the number of organizations that applied to LARA to say that they had excess capacity should the state need it during the surge. The list comprises 114 providers and indicates 5,400 available hospital beds and 210 extra nursing home beds. The interesting information inside of that is that none of those organizations, for the majority of those organizations, were called upon to use those beds. The second piece of information that helped informed our first recommendation on hospital capacity was the swing bed attachment you'll see over there. That swing bed document is a current listing of all of the swing beds in Michigan as they exist. However, during the pandemic, CMS waived the requirements for swing beds in Michigan. The Michigan requirement is you have to be a rural facility, and swing beds can only be a 10-bed unit in a hospital setting. What the feds have said is that during the pandemic, a swing bed can be rural or urban, and it can be of any size. So when we're thinking of hospital capacity and all sorts of alternatives, you can see how the group was looking at other forms of data to try to make our best decisions. So with that, the first recommendation out of our work group is that we recommend that MDHHS work with hospitals to identify facilities with excess capacity, including long-term care facilities, special surgical centers, and the use of swing beds to accommodate COVID positive residents. Also, if a hospitalized patient has less than 72 hours remaining in the overall isolation period, we're recommending that the hospital should keep the patient until the end of the isolation period. And we think that this will help slow the spread throughout Michigan. We know that there are certainly challenges in trying to do this. Hospitals have staffing challenges just like everyone else, and there are certainly reimbursement issues there too. But we do know that MDHHS has the ability to try to figure that out, and we think that would be a good step going forward. The second recommendation from our work group is that we're recommending the use of the regional hub program continue with strengthened protocols and guidance, updated to include on-site review of the facility's physical plant and compliance with protocols. MDHHS should prepare a pamphlet to describe to families and residents that this is a hub facility and they're being admitted to a hub facility. Additionally to this, I just want to remind everyone that the organization out of Ann Arbor called CHART, which is the Center for Health and Research Transformation, is doing a separate study on the hub program in Michigan. And we're expecting the release of that information simultaneously to the task force. So, we're going to be leaning on their recommendations as well around these regional hubs. The third area of our review was the non-hub facilities in Michigan. And I'm a little disappointed to report that we couldn't find consensus in our work group on this topic. The consensus that we couldn't find really related to the new admission of COVID positive residents to a non-hub. We found consensus within the work group that a facility who had a COVID resident could admit them. A return admission could be readmitted, and they could retain them. But the idea of introducing an external new COVID positive resident had some drawbacks, and the group couldn't find consensus on that. The main concern was the additional burden it would put on the facility, the residents of the facility, and the staff. And so we're still trying to wrestle that one out. Interestingly enough, the elected officials on our committee, I think, really tried to put a exclamation point on a couple points that I thought were worth sharing with the group. They said that if the flow of residents coming out of the hospitals doesn't change, despite the improvements that we've made in testing and on education, the legislature and the public will have a hard time believing that we were sincere in addressing our charge. And so, we know that there have been committees in both the House and the Senate reviewing the regional hubs and the care of our seniors in these environments. And I think that was really sage advice to the work group. So we're going to be meeting again next week to try to hammer something out and send forward to the larger task force. But right now, we don't have a recommendation where we have consensus on that one. The fourth area of our group was on the development of the COVID-only facilities. And just to summarize that, it just felt like in this short period of time, there really wasn't going to be a good way to stand these facilities up in Michigan and staff them and deliver the equipment and that sort of thing. So we basically said this might be something that may be more feasible down the road, but for the second wave, this was one we didn't really feel comfortable with. So with that, that concludes my presentation on our recommendations, and we'll go on to the next work group. Thank you, everyone.
All right, thank you very much for that, Dave. I am now going to turn it over to Barb Giles from Jewish Senior Life, who will comment on the Task Force Quality of Life Work Group. Thank you.
Hi, good morning, everybody. Again, this is Barb Giles, and I was on the Quality of Life Work Group. I previously had mentioned to you that that group is comprised of 15 members, 4 of which are providers, and I'm mentioning that because you'll see that is a bit of relevance later. In the end, our work group is coming forward with 14 sets of recommendations. You're seeing the first set of 7 here. They are in no particular order. However, we did prioritize them as high, medium, and parking lot issues. And as I describe each of them, I can tell you what their ranking is. So the first one that's on the list is that the Quality of Life Work Group recommendation felt that outdoor visits should be allowed and strongly encouraged for residents in long-term care settings. This is a high priority recommendation, and why we feel that this is happening is that there are many providers who seem to have a misunderstanding in the orders, and that became clear even just amongst the providers that are participating in the group. that there was different interpretations, and everyone's interpretation as a provider is trying to do the right thing for all the right reasons, but that there is just sort of a lack of guidance that creates these misunderstandings where some providers are actually restricting some areas that perhaps are not necessary to be restricted. So it came to our attention that there are facilities that are not even allowing residents to go outside. So that is really the key there. So, but we are recommending that outdoor visits be allowed and strongly encouraged. And we also felt that there was a variety of ways that this could be done and accomplished. So, but we did not necessarily discuss all the implementations that are possible, but we did provide options. The second one is providers will provide small group non-contact activities for residents. This also ranked high amongst our feelings of the group. And what we realized is previously there were work groups, and you might remember the high acuity congregate care setting work group met prior to this. There were other work group meetings. And so once the material was reviewed from the high acuity congregate care setting work group, it was realized that many of the recommendations that would improve quality of life were already made by this group. And that included, number one, outdoor visits. It included, number two, allowing for small group contact. So our recommendation and implementation was to refer back to that document that was produced as a guidance tool as well. Item number 3 was providers will provide limited communal dining for residents. Again, this was a high option, a high ranking priority. And again, this was also already recommended in the high acuity congregate care setting work group. And so we did recommend that again be reviewed, because recommendations were made in that document that did suggest that providers should be allowed the opportunity for this. And the high acuity congregate care setting work group did produce their work in different phases. So based upon the phase that we were in, we could respond accordingly. The next one, in number 4, providers will provide residents with options to participate in outdoor visitation. Again, some of our ideas, did I say outdoor? I meant indoor. If I said outdoor, I meant indoor. And we feel that this one is critical because part of what we feel our initiative is to prepare for the next possible surge. So we do think it's important for quality of life that providers be allowed ways to allow indoor visitation during the next possible surge. And again, there were recommendations in the high acuity congregate care setting work group to provide for this. And of course, it also included training and proper protocols and screenings and creation of specialty areas or areas that were near the front door or isolated areas or plexiglass areas, and allowed for proper cleaning. But all of this we felt would improve quality of life should there be a second surge. Item 5, providers will provide residents with the option to engage in small groups as a family or pod within the facility. Again, in planning for the next surge, we wanted to have some ability of quality of life to be addressed during the surge, which perhaps could be accomplished through the use of pods. And again, these pods would be driven by resident choice for participation, limited number of residents of 6 to 8, possibly in a pod, or possibly from the same unit or hallway, so that if there was another surge, that little pod could be isolated for evaluation and testing possibly. Item 6, Increase virtual visitation opportunities regardless of COVID-19 status. We felt that providers needed to be provided with a variety of electronic communication options, that there should be money made available for facilities that currently don't have internet or don't have capability to provide these tools to residents, and that some options could be looked at. We also even included making sure providers are familiar with clearinghouses that keep options about technology open, like our Leading Age Center for Aging Services Technologies. AARP has a clearinghouse. Consumer Voice has a clearinghouse, that we wanted providers to be familiar with the solutions that could be out there. Item 7, and that was high as well. Item 7, and now I'm having a change to a medium priority, provide additional creative activity ideas for nursing home staff. So this was creating meaningful activities to continue to improve quality of life. Many of our staff are being very creative, and our members have been doing a wonderful job providing activity ideas for staff, but not all facilities have the same wonderful staff and creative options that our members do. So we really wanted that to be across the board for anyone in the setting. The item 8, moving on to the next slide, Blake, is providers will increase resident supports for meaningful activities and engagement, especially for residents living with dementia or other cognitive limitations. We really wanted to make allowances for people living with dementia to improve their quality of life, that we really felt that perhaps there could be more CMP funding for resident engagement, that perhaps there could be, again, more options for electronic options that would be appropriate for people living with dementia. And again, could we use visitation booths or other designated areas with barriers to overcome the need for masks, which are very difficult for this resident population. Item 9. Ancillary services should be determined essential based on residents' need to receive the service of negative impact, whether it's physical, emotional, or psychosocial, on the resident when the service is not being provided. This was a high priority, and many of us have been talking about this. This is where non-medical service providers like clergy, religious, the hairdresser, the barber, all of these folks we believe should be allowed as essential, and the Quality of Life work group is recommending that these be permitted. And we do think that we were also recommending that this come along with testing of these individuals and screening and all of the appropriate safety protocols that would need to be considered. But we strongly feel that this recommendation needed to be pushed forward as part of quality of life. And I think all of us on this call agree with that. Item 10. Providers will be allowed and strongly encouraged to engage volunteers to serve as facilitators of in-person visits or virtual visits. This one was a medium priority. Everything could not be a high priority. But we really felt that we should be able to expand the definition of essential workers to include visitation volunteers, who at a minimum might help with visits with residents, help maybe conduct screening of visitors, escorts visitors or residents to visitation locations, and of course that there needed to be protocols around this. But not every resident has a family member who can visit, and these visitors really become the lifeline for quality of life for many of our residents. Item 11 is we thought that this is a high priority, and that MDHHS needed to offer clarifications on the order issued June 30th, the epidemic order. This was a high priority because we feel that, again, many misunderstandings are happening amongst the provider communities, And we really did not feel that we were okay, that there were some communities that weren't letting residents have the right to go outside without needing to be quarantined upon return. If they were just going outside for a walk, reading a book outside, enjoying the weather outside. And there seems to be some providers who actually are keeping that quite restricted. The other part of this clarification, we felt that there needed to be some look at the language about compassionate care in the order, because many providers are interpreting that as the very, very end of life, days or hours within death. And we don't think that that's really what compassionate care visits are, that people should be entitled to visits even as they're declining. So again, we felt that there needs to be more explanation and clarification. Item 12, providers will support residents attending off-campus appointments for medical, dental, health, optical, mental health appointments when telemedicine is not feasible. This fell into our medium priority, but we feel that it needed to be clear that people needed to be supported attending those kinds of appointments. Item 13 is that we felt, again, this is one of these areas of misinterpretation, that there are some providers who are not allowing window visits with somebody being outside and the resident being inside. So we felt that there needed to be more clarification about what entering the facility in EO 2020-156 really was, because many providers don't have good clarity on that. Item 14 is that we wanted to recommend the removal of independent living settings from the executive order. However, this one rated into our parking lot area, regardless of what some of our personal preferences about this might be, because many people in this work group really felt that this is at the nursing home level of care, that the work group was tasked with addressing skilled nursing facilities primarily. So this made it to the parking lot because it was independent living. However, I can assure you this area is going to continue to be pushed forward, because I do think the work groups are supposed to be more broad, but there was a big push that from some individuals that we should only be working on nursing home content. So those were our 14 recommendations that have been pushed forward. I'm sorry it was so lengthy. And if anyone has questions at the end, I'll be happy to take them at the end.
All right. Thank you very much for that, Barb. We will now move forward, and we will turn the presentation over to Nicole Mag from United Methodist Retirement Communities, who will comment on the staffing work group.
Good morning, everyone. So my name is Nicole Mag, and I have the pleasure of sitting on the staffing work group. We have 17 members, with 7 of them being providers. My experience with this work group, I think, is that it's been fairly unique in that this work group encompasses, frankly, a crisis that was occurring before the pandemic. So staffing and staffing issues was something that was plaguing many of us before we moved into the pandemic, unlike maybe the procurement work group. This group to kind of rein in a really big topic is staffing. So we had to focus kind of on 2 separate areas and hone it down to the highest needs. So to focus primarily really only. And this is our recommendation. I know working for CCA South that this is really just scratching the surface, but in order for us to provide recommendations in the very short period of time, we felt like we needed to be fairly specific. And then we also had to really think about future needs versus current needs, and then first wave versus second wave. So what do we need today? You know, what may we need in the future? And really, what are the bigger issues that are plaguing staffing in general? So we haven't actually landed on the final number of recommendations, but I think it'll be kind of around 6 as we continue this discussion. So you can kind of see on there the focused areas for the work group are really 3 things: adequate staffing, healthy staff, and then expert and engaged staff. So we tried to use that as our guiding post as we thought about CNAs in skilled nursing for these recommendations. And what we came up with and what the recommendations will likely focus on is more about filling the pipeline and keeping current CNAs and making sure that they're healthy and engaged. So for filling the pipeline, we felt like it was really important that we had one spot, an easy access spot for those that are seeking out a career in potentially being a CNA on one central website. Our recommendation would be that that would be housed at MDHHS and that it would be very easily accessible for anyone that's interested in that type of training or career to go to one spot to find all of the training locations, to figure out how to fund that, to figure out what it looks like to be licensed, to potentially have an experience of what it could look like to work in a skilled nursing community. So one central location was important to us. Next, we felt like we needed a public awareness campaign. I think all of us feel very intimately aware of the crisis before us, but I'm not sure that the state of Michigan as a whole really has an understanding as to the importance of these positions and the great need for them. So the idea being, if others understood how important, how valuable, and how much this position is needed, would that generate some people that may consider moving into this field that hadn't in the past? So that a public awareness campaign would dovetail nicely with a central location that we could send anybody that may be interested. Then we determined pretty quickly we had to get as many CNA training programs back up and running if they weren't already currently, and to potentially develop more, and that we likely needed state funding to do that. So there could be incentive funding created at the state level to partner with CNA programs, both to be created, to open back up, and to move more CNAs through the program. And then lastly, social supports available. We talked a lot about some of the social concerns that can plague our direct care workers, and a funded position that would exist in our communities from a social support level. So that could be, we talked about variations, maybe it's funding for an employee assistance provider. That was kind of one end of the scale, and the other end would be to literally have a social worker in the communities that was solely responsible for social supports for our direct care workers. A couple of really big topics that continued to plague us and were difficult to create future recommendations around was the idea of living wage and the pay increase that many in our group felt that CNAs really deserved and required, but then all of us know the difficulty in funding that and how we could provide a recommendation around that. So we didn't have something specific, although we did call out that it was likely needed to be evaluated, but it was a much bigger topic than we were going to be able to figure out in 3.5 weeks. The other big topic that came up was caregiver ratios. So there were some in the group that felt COVID warranted increased caregiver ratios, that things like the lack of communal dining and the lack of communal activities were requiring essentially an increased acuity for every single one of our residents, and therefore the state should mandate an increased ratio during the COVID pandemic. Some felt always that we should have higher ratios mandated at the state level all the time. But there was more support, I would say, for during COVID, that our current staffing ratios to meet the care needs of our resident weren't adequate because of the increased burden on the caregivers to do all of these very individualized services that are required today with the executive orders. So that was our staffing work group, primarily focused around keeping staff healthy and engaged by providing those social supports, and then filling the pipeline for new CNAs kind of as fast as possible. with the larger topics of pay increases, living wage, and caregiver ratios, a recommendation for a future task force to be developed to really give that the time, energy, and efforts that are required for this issue that existed before and has worsened during COVID. So thank you.
Okay, thank you very much, Nicole. We will continue moving forward, and I believe that we will turn it over to Deanna, who will comment on the resource work group.
Thank you, Blake. The resources work group spent time talking a lot about the challenges facing providers in terms of obtaining and funding testing PPE. And we also talked about reporting a little bit. We ended that discussion with a focus on the burden of daily reporting and not the content of reporting specifically. So the basic challenges included the burden of testing frequency. That is one of the high points that was discussed, especially considering that testing frequency is based on the amount of risk in these very large regions. And these very large regions can have high and low transmission areas within them. So, you know, there's a lot of discussion about that piece. And another challenge is, of course, finding a lab with the capacity to complete testing and to do it on a timely basis. So basically, the first piece is to relook at the frequency of reporting. Daily reporting, especially for the weekends, requires quite a bit of effort, and no one is really paying attention to the numbers that are submitted on Sunday unless we're in the middle of a huge surge crisis. So our recommendation was to tie the frequency of COVID reporting from nursing homes to the rate of transmission in the region, also noting again that we would prefer the regions be a bit smaller. But for now, just to reduce the frequency of reporting for moderate or lower risk levels to weekly reporting. That's what's required by the CDC for nursing homes. Additionally, daily recording is a staffing burden, and whenever daily recording might be required, we are asking the state to consider additional reimbursement for that time and energy. Additionally, relooking at the data reported and the necessity for each of those data elements we touched on briefly. And basically, we do know that most of the EM resource information that's currently required is really related to what the CDC and CMS requires. So the state doesn't have a whole lot of control over that. There are some additional state level data elements, but primarily the bulk of it is CDC and CMS requirement. The second piece we talked about was how we procure testing supplies and also access laboratories. So we're looking for a more highly coordinated system that's managed by the state, specifically managed by the state, that would provide real-time information about where there's a lab capacity with reasonable reporting times, along with a more specific state-level work toward increasing laboratory capacity itself. With the surge potentially coming, we know that laboratory testing times is going to be a challenge. The third recommendation was about obtaining PPE, and the recommendation focuses on the use of healthcare coalitions to work with FEMA and other entities to ensure that nursing homes are prioritized and not competing with other entities for necessary supplies. One of the challenges that the work group noted was that current suppliers were often not allowing procurement of PPE in numbers greater than what was supplied in the past, and that was just ridiculous. We are recommending that the state use its purchasing power to organize and manage access to PPE and also to manage pricing, because we do know that there were some huge pricing issues out there. We also want the state to review and evaluate how FEMA, state, and local emergency management, healthcare coordinating bodies, how they worked all together to conduct supply management during the pandemic and to develop a lessons learned plan from that. The fourth recommendation is about developing labs that are dedicated to nursing home testing, or at least designated to prioritize nursing home testing. The state continues to focus on the vulnerability of nursing home residents, and yet our nursing home facilities are not prioritized to receive the results or even get their tests done in a reasonable amount of time. Another consideration that we noted is how long the state will continue to pay for testing, and whether or not the state should be able to coordinate lab agreements and ensure there is lab capacity for each facility. Our final recommendation is about ensuring a continued funding stream for continued testing. And that would include the cost of additional staff for testing, the cost of testing supplies, and laboratory associated costs. Currently, testing is technically included in the nursing home daily per diem rate under Medicaid. And while other provider types under Medicaid are temporarily getting additional Medicaid funds for specimen collection, nursing homes and home health agencies were not included in that temporary flexibility. So we are concerned that when the grant money falls away, that nursing homes will have to take on these costs themselves. Other entities in Michigan don't necessarily have to do that under Medicaid. So we propose that the state include additional funding for specimen collection and testing under Medicaid should the grant funds now covering those items run out. So that is a very quick overview of the recommendations that are coming out of the resources work group. So Blake, let's see if there are any questions about anything relating to the task force.
All right. Thank you very much to everyone for all that information. Before we do get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic. And we encourage you to take a look at the names of the organizations up on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of names and consider making a purchase from one of these fine organizations. I do have a couple questions right now. I was actually going to ask the one for you, Dalton.
Oh, okay, go ahead.
Yep. Is the job portal only for SNF, or can HFA and AFC also participate?
Well, that's convenient because I wanted to make a point of clarity. That portal is for any licensed provider, so AFC and HFA can participate.
All right. And then it looks like I have one person who said it would be helpful if Connect to Care Jobs opened up registration beyond just the administrators. Our HR recruiter has been trying to get a login for about 4 weeks now. Apparently only administrators of the licensed providers are in as registered users, and they are likely not going to be the ones managing this portal listing jobs.
Well, that's a good comment. We will definitely forward that on to the state.
All right. It looks like those were the only two questions that we had so far. So looks like we can.
Okay. Well, we have another question period at the end. If people want to formulate any further questions, we can move on to our situation update. We're going to do a very, very quick overview of just the Michigan numbers this morning. So the next slide, Blake, is the 7-day rolling average of new Michigan cases for the last 60 days. This is the graph that we put up all the time, updated as of yesterday's numbers. The numbers are looking promising, so we're kind of excited about that. They look like they're leveling off, and hopefully, perhaps we can start on a more downward slope again shortly. The next slide has the graphic for the 7-day rolling average of Michigan daily deaths for the past 60 days. You can see that over the past week or two, we've had an increase in deaths. But again, it looks like it could be leveling off, and we're hopeful about that as well. This is the My Safe Start map as of yesterday, August 20. You can see there's been no change in the overall risk categories for each of the 8 areas, which means that weekly staff testing for nursing homes will continue across the state. So now we're just going to move on to a few very brief updates as of today, pretty much since we last met on Wednesday. OSHA Compliance. Here are some brief reminders about OSHA Compliance. We have not specifically heard of OSHA issues being a problem in Michigan, but we do know that in several other states there have been some serious citations. So we wanted to remind members that staff illnesses and injuries have to be reported to OSHA using their log. Reporting for any work-related issues leading to death, days away from work, restricted work, need to transfer to another job, anything requiring medical treatment beyond first aid, or any exposures that lead to any of those conditions. So this is very pertinent considering the pandemic. It seems that what's happening in some other states is that when a facility fails to report these work-related illnesses, and OSHA finds out about that it has triggered a full OSHA survey at these facilities. And a lot of these facilities have been cited. The most frequent citations from those surveys have included failure to have a respiratory program if you're using respirators such as N95s, ensuring related fit testing for that, whether or not the facilities documenting their efforts to obtain required PPE when supplies have been lacking, and of course citations for not having enough PPE. So we just wanted to give our members a little bit of a reminder of the OSHA requirements. The next slide, this slide has some of the related OSHA guidance in terms of reporting and respiratory programs, so we thought we'd provide that in case anyone needed to refresh themselves about it. This week, the department issued notices to any nursing facility or other provider who has requested state help for COVID testing. So the state has always said that they are going to eventually contract for testing support with a private organization or agency. So the state is moving from using the National Guard for these purposes and is in the process right now of transitioning that work to a contracted testing provider called HONU. The department also notes that HONU has the ability to use saliva tests, which would eliminate a lot of the discomfort involved with specimen collection. And return time is also thought to improve if they're assisting you with testing. So anybody who's requested state assistance with testing, and the information for that is in the testing guidance that we've talked about quite a bit. The company representative will be contacting any provider who has requested state assistance, and they will be transitioning to this new entity. So one of the things that we haven't done a whole lot in our webinars is report on the governor's phases themselves. This is from a web page that is linked off of the My Safe Start map page. And of course, this map uses the same regions, but it categorizes each region based on a set of elements in terms of risk. And those elements include the rate of new infections and the rate of spread in an area, whether or not there's sufficient medical personnel, hospital beds, or ventilators available, whether or not there's enough PPE for the workforce, the state capacity for testing, the ability to isolate in response to testing, and the overall economic conditions. So as of yesterday, the current phase status for each region is noted on this map. And the link to that specific web page is included at the bottom of the slide. So when we look at the wide range of possible phases, the state looks as if it's doing fairly well. The yellow areas are improving, and the blue areas are containing. So that's really good. I don't think this has changed much, though, recently, although we haven't looked at it closely. The regions are important for several reasons. A lot of the reopening plans, as identified in the executive orders, are based on these. So there's differences in certain industries in what they can do based on the phase in that region. But it's also important now because the new guidance for restarting long-term care ombudsman visits is based on the phase in each of these regions as well. So the long-term care ombudsman, along with the Aging and Adult Services Agency, has put out a rather detailed guidance about restarting those visits. And there are several documents issued by the Aging and Adult Services Agency and the Ombudsman's Office, and they are noted here. We will be providing these out in one of our updates as well so that you can link directly to them. So we're going to do a very brief review of the guidance. The guidance is quite long. This is just a very quick overview. They've identified that visits can take several forms. They can be virtual, window, outdoor, indoor, or in person. And if you think about the regional COVID phase map that we just looked at, obviously the virtual visits can be made in any area for any phase. But then you'll see a progression toward in-person meetings based on the phases that each region's in. So right now, most of the region is in phase 4, and there are 2 regions in phase 5. So for the lower part of the state, window and outdoor visits would be allowed right now, and indoor visits only for the northern lower and the upper peninsula. However, there would be no indoor visits if there is an actual or suspected case in the house. They will also not enter the facility if they believe that inadequate infection control is there. Ombudsmen must self-screen based on the requirements from the agency where they are housed, and they also must be screened at each facility if they enter the facility. In fact, one of the things that they're going to be looking for when they do visit is adherence to screening at each facility. So the ombudsman is going to be looking at your screening processes as they come into the building. Each ombudsman staff must go through a very detailed list of specific trainings, and that's required before any visits will restart. And unfortunately, though, just like surveyors, they're not required to undergo COVID testing. So they have also developed a priority list for visits, and they anticipate that any on-site visits will be limited to 1 per day. If it's necessary to do more, they will be asked to have a change of clothing. So they don't want to be moving in and out of facilities every single day as a precaution. Some of the priorities for making visits are listed here, and the memo includes some detailed context all around that as well. All of the associations have been asked to forward this memo and the other documents to our members so that everyone's aware that the ombudsman visits are going to be restarting. In their process guidance, which is extremely long, there's quite a bit of information about how they will plan and coordinate with each individual facility. So there's a visit checklist that members should review, a list of information they will want from each facility. So there's a whole section in this guidance about what's expected from the facility, and we suggest that members look at that. So that ends our webinar for today. I will turn it back over to Blake.
All right. Thank you very much, Deanna. Again, Leading Age Michigan just wants to thank our sponsors and our exhibitors from our postponed annual conference, and just want to remind you, if you are considering a purchases of goods or services, just please remember these fine organizations and consider purchasing from one of them. So I will. Right now, I actually do not have any further questions. So I will pull up this page right here. If you do think of anything, you can reach out to anyone on the team, but we do have the Safe and Calm email there. Multiple team members would see that, so you can go ahead and shoot an email there if you have any questions, or you can reach out directly to Deanna, Dalton, Laura Funch, or you can reach out to myself, Dave, pretty much anybody on the team, and we will get you in contact with whoever you need, or we will help you answer that question. Other than that, we would like to thank Barb and Nicole and Dave, everybody, for joining us today. I believe we also had around a little over 70 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I did just have one question come in while I was reading that, so I will go over that really quick. Can you give clarification on the wearing of face shields and sniffs, and clarification of June 30th guidance from MDHHS on expectations to restrictions on entry? Can you hear me, Deanna?
Sorry, I put myself on mute.
No, you're fine.
Currently, eye protection is recommended by the CDC for all healthcare facility that's specifically required by MDHHS as well. We did go over this in the August 6th, through the August 6th memo that updates to the MDHHS guidance on Wednesday. For all care in areas of moderate to substantial transmission, which is the entire state of Michigan right now, people are expected to wear at least a surgical face mask and eye protection, which could be shields or goggles, and N95s are recommended if they are for COVID care for sure, for all care, if indeed there's enough supply. The second part of the question, to be honest with you, I don't have that guidance in front of me, so I will have to look at that piece and get back to you.
All right, and then I just had a comment that somebody said, a surveyor here last week said eye protection is a must and is not optional.
That's correct. It is a must. It is not optional.
All right. I believe that takes care of everything. Deanna, do you have anything else you would like to add?
No, I just like to wish everybody a nice afternoon and a good weekend, and to kind of keep the faith as we move forward during this really hard time.
All right. Thank you very much, everyone, and we will see you guys next week. Have a great weekend.